Good evening, America. It is that time. It is 5 o'clock on the Gulf Coast, which means it is time for Fertility with Fink and Friends. I am Fink. You are Friends, and it is wonderful to be here with you tonight. It's 6 o'clock on the East Coast, 4 o'clock in the mountains, and 3 on the West Coast. And this is a place that we come every Tuesday evening to talk about all those things that are important. That is things about having a family, things about getting pregnant, things about staying pregnant, things about all those things that you think are important. And I am happy to be with you. My name is Dr. Randy Fink, and I am a fertility gynecologist at New Life Fertility in Pensacola, Florida. We also have offices in Mobile, Alabama, and Panama City. And I also work with the fine folks at the Missouri Center for Reproductive Medicine, that's MCRM, in St. Louis, as well as in Tulsa, Oklahoma. So good evening to everybody out there. Thanks so much for being here tonight. Special hello to all my friends who are joining here. Let's see, Andre, thank you. You are number one. It's great to see you here tonight. Noodles, good evening. And the Bama Gal in Mobile, my wonderful mother and father in Mobile sitting, joining us here tonight. Thanks so much. Logan, the therapist in Northwest Arkansas, thank you for being here as always. And I will again give a great plug to Logan, who I actually haven't had the pleasure of meeting in person, but my interactions with Logan have always been very, very impressive. A wonderful therapist. So if you are in need and have an understanding to be with someone who has an understanding of what you're going through as far as the fertility world goes, Logan the therapist is the name on Instagram. Rosa SD, good evening. Hi, Macy in St. Louis. Thank you for being here. Miss C.R. Tyler, Mrs. Pittman, nice to see you. Marianne, Jazzy Poo, good to see you. Hi, Queen Bee. We've got the Pensacola Wellness. Hello there. And Elena, good evening to you, Elena Gallagher. We've got a couple of different feeds here. We've got my Instagram, which is right here. That's Randy Fink, MD. This is New Life Fertility right here. And we've got Facebook for New Life and the First Fertility Group and MCRM, as well as LinkedIn and YouTube right here in the middle. If you've got questions tonight, please throw them my way so we can make sure that you get the answers that you need. And that said, let's jump right in there to Andre, who says, sorry to jump in so quickly. I invited you, so that's a good thing. Can you explain what causes empty follicles and what can we do to improve this? You know, it's a very good question, because when I see, so basically what you call empty follicles is a situation where you are growing a follicle that is being followed during the process of IVF, and it looks like there is something there. And then you go to retrieve it. And when you do your retrieval, come to find that follicle did not have an egg in it. So the first thing is I always, wonder about is were you triggered adequately? So did your trigger shot happen at the right time for the retrieval? Because, you know, what it looks like is that in your follicle, which is literally, that follicle is like a little egg house. It's a little sac of fluid with a microscopic egg on the inside. The egg kind of hangs out on a little stalk on the inside, and it's attached to that stalk. And part of the process of its maturation is that the stalk has to release and the egg has to float freely within that fluid. Now, if you were to ovulate on your own, then that ovary starts to act like a squirt gun, you know, and it goes and it squeezes out the egg. The egg gets released. But otherwise, you know, when we're doing IVF, we want those eggs to become released within the follicles. We don't want them released in your eggs because we want to be able to retrieve them, right? We want to bring those to the lab so that we can fertilize them. Well, if you put a needle and you suck the fluid out and there's no egg there, the first thing I have to wonder is that egg still attached to the stalk? And that is a function of the trigger. And that's one of the reasons that I almost always use a double trigger, that is using both Lupron, that um, triggers that stimulates the pituitary gland to cause your own LH surge that results in you naturally releasing that, and some HCG, which is the pregnancy hormone as well. HCG also directly stimulates that egg to get released. So I'd want to make sure that the timing was right, and that the trigger was adequate so that we're not actually leaving eggs behind. And so when they've studied this, what they've learned is that in most cases, Andre, when there is an empty follicle, the issue is likely more that the egg is still there. It's just stuck on the inside. And the way that we retrieve these follicles, we don't necessarily always get really a one-to-one follicle to embryologist feedback to know that this follicle had an egg and here it is. We typically go through and retrieve multiple follicles. That fluid all goes into a little test tube that then goes to the embryologist, who then looks under the microscope to see what was there. So we don't know, the way it's done is that we can't tell that one of those follicles may not have had an egg until it's kind of well after the fact. So what can you do about that? Well, before we talk about that, let's talk about some other potential scenarios. Empty follicles also can go along with the process of aging. And that is, the more mature we are, the greater the probability that there's a group of eggs that are hanging out, and they're surrounded by granulosa cells, which make your estrogen. But some of those little houses are actually empty houses just because the granulosa cells are there, but the egg itself is not. And that's a function of aging. There really isn't much that we can do for that particular scenario. The other is that the egg was there. It's just that we waited a little too long to trigger you, that the egg became post-mature, and therefore it became what's known as atretic, which means that essentially it just dissolved. Remember, those eggs are just, they're little tiny single cells. They're very, very fragile. And if they're hanging out for too long without really being told what to do, the issue is that they can just sort of dissipate. That too is something that is more likely to happen as we age, but is a function of when you trigger relative to the well, actually, really, when you trigger relative to the retrieval, but also if you waited a little too long to trigger, an egg can become post-mature, and then it starts to decay. That was a really good question, my friend. So thank you very much for asking that. Let's see if we've got anything else going on here. Well, Logan, the therapist, thank you for the kind comments there. Love the work. Thank you. Appreciate that. Noodles for Life. Is suppression necessary for FET, for silent endometriosis? My lining is not responding after almost 5 to 6 months, losing an effectiveness window, and restarting suppression might get similar resistance. Yeah, so you've had a hard time with this. I know you really have. And I, this actually reminds me of one other thing. And before I answer that question, I just want to say also, happy Tuesday, by the way, to everybody. And I hope that it was a very happy Mother's Day for everyone. But I've got to say, Mother's Day can be a bittersweet thing for all those who are dealing with fertility issues. And our friend Logan there said it once very articulately, so much so that I saw it on a post and reposted it from New Life. You have to be gentle with yourself. Be gentle with yourself. And on Mother's Day, it can be very hard to kind of see all these other people celebrating, knowing that the celebration that you want for yourself is just feels so just right beyond your reach, that you feel so close but not quite there yet. So Mother's Day has mixed reactions for folks who are going through fertility. And I just want to say, I hope it was a wonderful day for you. I hope you were able to celebrate some with your mom, as I was able with my mom, and treasure what we have. Because if you weren't there yet, your time will come. I sincerely believe that. Okay, so that was my 2 cents worth on Mother's Day there. Noodles for life. Okay, suppression. Yeah, you have had a hard time of things because, you did suppression for endometriosis, and by all accounts, it appears to have knocked out your endometrium. That you keep going back and looking, trying to do an embryo transfer, but you're not making an endometrium. And so, gosh, Noodles, have you done an FSH? Do we know where your FSH is and know that your hormones actually have recovered from that suppression? Because that's the first thing I'd want to know. Are you making enough estrogen? Even though I know that in your medicated cycles, you were getting estrogen, which should have made that grow. I would not, in your situation, do more suppression for endometriosis. I think, you have to weigh the pros and the cons. You have to weigh, the benefits against the risks. And already that one round of suppression seems to have had such an impact on your lining that I would definitely not recommend that you do that again. But I'm still very concerned as to why you haven't grown your lining there. Really makes me wonder. Marianne, thoughts on RI and RE collaboration to support recurrent implantation failure. So an RI is a reproductive immunologist, and an RE, of course, a reproductive endocrinologist. So in certain situations, I do refer to reproductive immunologists, but the problem is there are only like 5 of them or so in the country. They are hard to get into. They are expensive to use. And to be honest with you, and what will happen is that they will do, maybe $10,000 worth of testing. And in many cases, we might just opt to treat you with an immune protocol for all these things, even without that testing. So I do believe if you've gone to see a reproductive immunologist, I find their input to be invaluable. It's great to have it, but I don't always suggest that patients go to see an immunologist because sometimes, it takes a long time to do it, and the information we get may not be any different than how I might otherwise want to treat your immune system. Recurrent implantation failure is one of the more frustrating things we deal with, just like Noodles for Life with the issue, regarding not growing that lining for transfer. Very frustrating problems, but there are a host of immune interventions. Probably the first one, the number one thing that I have found helpful for recurrent implantation failure is the use of tacrolimus or Prograf. Prograf has been shown used in 3 milligrams of Prograf in divided dose, so either 1.5 twice a day or 1 milligram 3 times a day, to probably be the most effective intervention for those who keep putting embryos in and the embryos aren't sticking. It has a very significant effect. Now, my guess is, Marianne, you've probably already tried that. You've probably already done that. So now here's one other thought. If you're not familiar with it, there is a test that you can do that's called Pregmune, 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 and their website, pregmune.com. And basically, what Pregmune is sort of like an AI version of a reproductive immunologist. For a fee, you elect to enroll with the program. They will send to you requisitions through Quest, LabCorp, through your insurance lab, and you can go and have a whole host of these laboratories done, all the testing that would be involved if you were to go see a reproductive immunologist. They then run those results through their proprietary AI and produce about a 70 page report on your entire immune system function that will really kind of give you the same thing as you would get from seeing a reproductive immunologist, but also a test that you can provide to your doctor, who can go over that with you. Now, I will say that many of the things that show up on there are things that I would never know how to test and that I would never know how to interpret. They get pretty granular, they get pretty esoteric. And I have to say that, to be honest with you, some of them I don't really know the significance of. But at the end of that report, it gives us a series of recommendations. The big gun that's always there for recurrent implantation failure is IVIG, which is IV, intravenous immunoglobulin. And it, as I say, biggest gun we have for immune function. The problem is it's very, very expensive, and it is not FDA approved specifically for that use. So in most cases, insurance will not cover it. And so therefore it gets tricky. One of the things that these reports, whether it's actual reproductive immunologist or if it was just, kind of through Pregmune, they will often say, consider the use of IVIG. And I would say, I already consider the use of IVIG. And so, there are a bunch of different immune interventions, and many clinics know how to use those even without the reproductive immunologist. But if you see one, I think it's a great thing. I always value their input. Manda, good evening. Thank you for being here. Wow, I've got Manda and Macy. Sorry, Macy, I couldn't think of the name. Manda and Macy together. Wow, what a team. What a team from MCRM. Okay, let's see what else we got going on here. Over on the Facebook side, Maddie May, good evening to you, my friend. Praying that our IUI takes. This 2-week wait is not for the faint of heart. And oh my gosh, you are absolutely right on that. What are your thoughts on taking a break after unsuccessful IUI versus continuing in consecutive cycles? So, thank you for asking that question. We do spend a lot of time on this program talking about IVF and other things in fertility, and it's not the only treatment that we can offer. So, Maddie May, you have done an IUI, and you are right. The time from doing that IUI to waiting to get that pregnancy test is interminable. It feels like it takes forever. You're sitting on the edge of your seat, just wondering what's going on down there. So when we are doing IVF, doing consecutive cycles or back-to-back cycles, or what we also call stacked cycles, has been shown to have a benefit, that the medication we use tends to stack itself in the ovaries and can continue to help you recruit eggs over the course of about potentially 2 to 3 months. So it's not that the medication stays with you and continues to cause you some kind of potential problem, because it doesn't. But the effect on egg recruitment and on the pituitary gland can be such that it is beneficial to do sequential cycles. With an IUI, that same is not true. So if you decide to take a break after doing an IUI, if it doesn't work, you are neither helping anything nor harming anything, at least as far as the fertility treatment goes. Now, it may be that it was such a trial on your patients, that your heart was so invested in it, and if it didn't work, that you kind of need to take a break for your own sanity, in which case that break doesn't harm anything at all. But there's no reason to think that either doing them sequentially, back to back, kind of gets you towards your pregnancy goal a little faster. But there's neither harm nor hurt to either taking a break or doing them in a row. Now, the thing that I have to, I feel compelled to say about IUIs, the first cycle is just as effective as the second cycle, which is just as effective as the third cycle. So if it works the first cycle, I'd say, man, that is fantastic. That is just really wonderful. And congratulations, that was great. But if it doesn't work the first cycle, that doesn't mean that there's a problem, because this is still very much a math equation. It's still very much about getting the right sperm together with the right egg at the right time. So we got the right time part. We know how to separate out that sperm and to hopefully give you better sperm if you're doing an IUI, or even if it's just timed intercourse, then it's still about the right sperm getting there. What we're helping with there is the timing. So if it doesn't work the first cycle, same success rate in the second cycle, same success rate in the third cycle, which stands to reason. And I try to warn people about this. Please don't be so invested in that first cycle of IUI that if it doesn't work, you are brokenhearted. I think it's completely reasonable to be disappointed, because, we all have our hopes. It'd be great to just kind of get it over with. But statistically, you are at every bit as high a chance in getting pregnant in that second cycle and the third cycle. So do not give up hope, Maddie Mae. Do not give up hope. Praying for you, says Kelly. Yes, indeed. And fingers are crossed from all of us out here to you. Lana is here. Good evening. If you're using donor eggs, Lana asks from Facebook, and you have a positive Tessie, how do you prepare for an FET, and how long does it generally take to prepare for a frozen embryo transfer? So I think you mean that, so you're using donor eggs. So the process for using a donor egg is that, you select your donor. You get the lab at your practice to approve the donor. Those eggs are shipped. You do the Tessie, which of course is a testicular extraction of sperm. And that can happen for a number of reasons. That can happen because partner has had a vasectomy. That can happen because there are issues with morphology and we need to get better sperm. That can happen because there is no appreciable sperm count on ejaculation. Maybe because of retrograde ejaculation, or maybe the testicle's just not making enough sperm. So in that scenario, we do a post vasectomy, 27 years. All right. So what we're talking about is someone who's had a vasectomy. So that means that the plumbing is unplugged. You're making a gazillion sperm. They just have no place to go. So you place a needle inside the testicle and you get the sperm from the testicle. So different things can happen there. That sperm can be frozen. That Tessie specimen can be frozen, which is usually what we do, so that if it doesn't work the first time, that then if you go back for another cycle, he doesn't have to do another needle in the testicle again. So usually it's divided up into about 4 different specimens and can be frozen. Then that gives you some leisure about what to do with the egg. Now, if we know that there's going to be sperm there, then they may go ahead and thaw the egg, but thawing an egg really doesn't take very long. So as long as the donor eggs are there, so if the Tessie is being done at another site, usually it's frozen and brought to the lab, or it's brought fresh. And then once sperm are confirmed, the egg is thawed and fertilization takes place. That's kind of how that goes. How do you prepare for a frozen embryo transfer? Well, so usually, there's a couple of different ways to do an FET. We can do that through a medicated cycle. We can also do that through a natural cycle. And depending on which you're using, is whether you get the estrogen and progesterone from us or whether your body is making the estrogen and progesterone. But things that you can do at home, and kind of, when it comes to that, you have to sort of rely on your nurses and on your doctor to guide you towards the right path. But there are some things that you can do that will help you with embryo transfer. There is an evidence-based supplement protocol. What can a handful of vitamins do to help us get pregnant? Prenatal vitamin, you're supposed to be on that thing for 3 months before conceiving. Fish oil, DHA, omega-3 fish oil, vitamin D, vitamin E, CoQ10, and L-arginine. Those are the 6 things associated with better outcomes from a frozen embryo transfer. So I would strongly encourage that you think about doing that. And that is the best thing that you can do for yourself at home to prepare for that FET. Elena asks, what do you recommend to reduce anxiety if I start thinking about my age and my chances? I've read it's important to be relaxed. It will increase the odds. I absolutely do agree with that they've actually studied the use of hope as it pertains to doing fertility treatments. And those who have a more positive outlook oftentimes do better. So what can you do for anxiety? What is anxiety? Anxiety is really just that process of worrying about all those things that we can't control. It is your mind's construct to keep itself occupied because, as I've said on this broadcast before, we are hardwired to be monitoring for danger, going all the way back to our caveman days when we were watching for the pterodactyl to swoop down and steal our baby or the saber-toothed tiger to leap at us from the tree line. We're always monitoring for danger. And even when danger may not truly be readily apparent, we find it. Our brain finds it somehow. It gives you something to worry about. And so does it pay to worry? Well, I would say no, it really doesn't. All it does is allows your brain to kind of justify its own existence. Mindfulness is a very important tool that you can use that is very useful for treating anxiety and for dealing with anxiety. One place, calm.com, has wonderful mindfulness exercises. There is a website that I have talked about before here. It's an app that's called New Calm, Nucalm, newcalm.com. New Calm allows you to essentially, you kind of listen to some what sounds like music. It sounds like spa music. But what it actually does is that it programs your brain waves in that period of time and literally eradicates some of the stress from the level of the brainstem. This is actually used by many, by Fortune 500s, by NFL teams. Lots of people use it. It's a very well-established protocol. It has done wonderful things for me in my life. And actually, there is a discount code that you can use for that, and that is SLEEP15. SLEEP15 gets you, I think, a 15% discount on the New Calm subscription. I think they do it monthly, and gosh, I really can't speak enough volumes about what it has the potential to do for you in terms of dealing with anxiety. Is it worth worrying about? Our minds tend to catastrophize. We think of the worst possible outcomes. We think of all these catastrophes that could occur as a result of whatever's going on in our lives. And the truth there is that more than 99% of those things never happen. Those boats never leave the dock. They're not real. It's a construct of the mind. And I would say that there is one other sort of idea that's interesting to me, and it comes from a book that is called The Power of Now. And the power of now is basically telling us that what happened in the past is just a memory. It's not real. It happened, but it's not real. What's happening tomorrow that we're anxious and worried about is also not real. It's all just a construct of the mind. That the only thing that matters in the world is what is in front of you right now. And when you empower yourself to understand that power of now, it makes a lot of the rest of that stuff really just seem like what it is, which is noise. It's not an easy book to read, The Power of Now, but there are quick synopsises of it, and it's actually a very powerful piece of knowledge to carry with you. The past and the future are just constructs. What's here in front of you is now, and that's really what matters. So that's my thoughts there. And yeah, I do think that having hope and trying to jettison some of that anxiety really does certainly makes for a happier existence, but I do think it makes for better outcomes as well. Positive vibes means positive betas. How about that? Hey, it's a little half past the hour here, so it's time for the 5:30 Fuzzies with Fink. The Fuzzies with Fink is about the time that we all get together here and do break the internet with kindness. It's the point where we can send out all the positive vibes to everyone out there who's having a difficult time. Everyone out there who is dealing with fertility issues, who are all the folks who are feeling pain tonight, whether it's from fertility treatment, from hoping, from wishing, whether it's things about relationships, school, work, family, whether it's dealing with the issues that surrounded Mother's Day, which was not an easy thing for many fertility folks to deal with. This is the time that we all stand together as one community, put our arms around each other and say, you got this. This is going to be all right. And you are not alone, because it often feels very lonely to be in this place. And sometimes you can be alone in a crowd of people and just not know where else to turn. This is the chance that we say together, we're all here for each other. So if we can right now, send all those positive vibes to everyone out there who needs them tonight, who needs to know that they're not alone and that tomorrow is a new day, and that new day is full of all new adventures. Because friends, it really is. It really is. And that's the 5:30 Fuzzies with Fink. Thank you for sending your vibes out there to everybody who needs them tonight. Thoughts, prayers, hugs, and kisses, and all the things good to everybody who feels alone. Okay. Hi, Red Bear. Good to see you here tonight. Let's see. Who did I see? I saw Tracy down in Miami. I see Aaron. You're probably not there anymore. Jay Palmyro, hello. Mrs. C.R. Tyler says, my CD138 came back positive on our gestational carrier. She was treated with 2 weeks of 2 antibiotics almost 2 months ago, and her retest came back negative. Does she still need to take Doxy before the frozen embryo transfer? So what you're saying there is that she had a test for CD138. CD138 is the marker for plasma cells, and plasma cells are the marker of a chronic inflammation. And that's what chronic endometritis is. If you had an acute infection in the uterus, you'd be sick. You get sick from that. You would have fever. You would have a lot of pain. You'd have this, yucky discharge. You'd be sick from that. But you can get a sort of a smolder inside there, and that's what chronic endometritis is. It is represented by a particular type of immune cell, a plasma cell, that says that things are all kind of fired up in there, but it's just smoldering. It's not blazing out of control. And that inflammatory process can create a hostile environment for your embryo to implant. So that's what we treat. CD138 is the marker for those plasma cells. And so we treat that with classically with 2 weeks of doxycycline. The best data shows us that doing a test of cure after that gets us the best kind of pregnancy outcomes. And it sounds like your GC, your gestational carry, got tested. It was negative. So why do we use doxycycline during an FET cycle? Well, it's not so much to treat chronic endometritis or bacteria up on the inside, but rather it lowers the colony count of bacteria that may be in the vagina and also in the cervix. Because, you know, for that embryo transfer, we're taking that little catheter and we're placing it in the cervix into the uterine cavity. And so we may be seeding the uterine cavity and creating a situation with chronic endometritis for next time. So my answer is, yeah, I do recommend that you treat with the doxycycline precisely because she had chronic endometritis before. We don't want her to get that again. So that's what it does. It's not, it's really just it's more preventative. It's preventative. That's the way I would think about it. Good question there. I think I already said hello to Tracy. Rosa asks, is hysteroscopy and a saline uterine ultrasound as effective as each other before a transfer? Which do you recommend? So what we want to know is that the uterine cavity is normal, right? We want to know that there's no polyps, that there's no fibroids, that there's no bands of muscle or scar tissue, really anything else on the inside that's going to keep that beautiful, perfect little embryo from taking up residence on the inside. In theory, both of those tests should be equivalent, a saline sonogram or a hysteroscopy. Now, that said, the hysteroscopy is really the gold standard because with hysteroscopy, we're seeing it with our own eyes. We're not trying to interpret it based upon the black and white and shades of gray that we see with an ultrasound. We are actually looking at it with our own eyes. The other thing I do with a hysteroscopy in most cases is that I will also take a little sample of that tissue so that somebody can look at that under the microscope and tell us two things. One, that your brain is talking and that your uterus is listening, that the hormonal environment is as we would expect for it to be at that time. And two, that there's not that chronic endometritis situation going on there. So my personal opinion, I prefer a hysteroscopy. But if the hysteroscopy is not possible, if the patient prefers not to do it and would rather have a saline sonogram, I think that's fine in most cases as well. We were talking about Noodles for Life and her uterine lining. Your FSH at baseline is 4, which means you ought to be making enough endometrium there, and the lining plateaus around 6 millimeters. Tried all forms of estrogen, PRP, Viagra, and vitamins. Sounds like you've pulled out all the stops there. And you basically will make it to about 6 millimeters. That may be the best that you can get. There's data that shows us that, in folks that's the best they can get, they still can get pregnant with that. Now, optimally, I like to see 6.5 millimeters if we can get there, certainly 7, even better. But at 6, I'd say, Noodles, if that's the best you can do, I wouldn't cancel a transfer for that. Now, the other option is to be on some estrogen for an extended period of time, and you may have done that too, just to see if there's any time relationship there. It's very unusual. I'm not sure that I have seen a situation where a patient has done suppression and it knocked out the receptors for the estrogen such that then when you got the estrogen, it didn't cause the lining to grow. I would think in all cases, given enough time, those receptors would come back. Just my opinion there, but gosh, fingers crossed for you there for sure. Hi, Lisa in US, Indopino Journey. Good evening. Let's see. Logan, the therapist, says, what is that report called? and where to find. Not sure which report. Let's see. We talked about Pregmune. So Pregmune, PREGMUNE.com is it's not an inexpensive proposition, but it's like seeing a reproductive immunologist. We talked about calm.com. We talked about NuCalm, NuCalm, with the coupon code of SLEEP15. I think those were the three things I mentioned there. So hopefully you were asking about one of those things. Hi, Sheila. Good to see you this evening. Elena asks another question. I'm 41 and I've recently had an initial consultation. I started taking vitamins. What general diet and exercise do you recommend to increase the chances? Well, what we know about diet and exercise is that certainly people who exercise do better. They do better in life. There's less inflammation in the body. But what kind of exercise is said to be the best? Unfortunately, there is no good data to answer that question because it's really what your body is most used to. So what I wouldn't do is say that you need to start some really intense exercise regimen because, Orange Theory or CrossFit or marathon running, one of those things is going to be better for you because in all probability, actually, it's more likely to injure you or cause harm. It's gentle exercise, it's gentle aerobic exercise and gentle resistance exercise, but basically getting you to the point where you're just kind of comfortable moving, your heart rate gets up, and you're keeping things kind of stretched out. That's really, I think, the best or really what we would call moderate exercise because too much more than that really, is not what your body is used to. And when it comes time to go through the process here, we want you doing, teed up, but doing what your body is most used to. From a diet standpoint, there too, there is no good evidence that one diet is better than another. However, certainly in the fertility space, as we talked a little bit about last week, there is a lot of noise out there about keto, a lot of noise about carnivore. You must be doing this or else you are trying to kill yourself. The vegetables are trying to kill you. If you're not doing it, you're insane. You're crazy. It is the one thing to do. And again, I just don't buy that. There is not science behind that. Now, the people who believe it with a fervor and almost with, to the point of religion and can have very, very intelligent discussions over why that's so. And I don't dispute what they believe in any way. All due respect to them. However, the data shows us, science, when you study it methodically, says there is no one diet that's better than another. So whether that is keto, whether it's carnivore, whether it is the Mediterranean diet, personally, I kind of subscribe to a bit more of the Mediterranean type diet because that's the heart healthy diet. That's the one that's been recommended to kind of keep your heart going, keep your heart beating. Keto is high fat, moderate protein, and low carb. The one thing, and I actually like keto. I just think it's kind of unsustainable. It's hard to stay on long term. The one thing that really every one of these diets has in common is that carbs are the enemy. You want to be able to limit the carbs as best you can because carbs are pro-inflammatory. And we know that inflammation is ultimately at the cause of really pretty much every disease process we know. Exercise that you're comfortable with. And Red Bear says, exercise, woohoo! Exercise that you're comfortable with and a moderate diet. Again, whichever one that you're most comfortable with is the one that you should stick with. As I think I said it last week, you can't sit in the bathtub with all hot water or all cold water. It has to be a mixture of both, right? Um, because cold and hot, it makes it warm, it makes it tolerable. And if your belief system is all the way on one side of the spectrum or all the way on the other side of the spectrum, chances are it's not something that you'll be able to sustain. It's not something that's mainstream enough. And you may believe that your side of the spectrum here is so very powerful and right, but really for most people, it's some blend of those two things that makes life livable. Hi, E. Winnick. Good evening to you. And let's see, Tara. Good evening, Tara. Hi, Midgie and Marlena and Angela Sack. Good evening there. GPTV. Howdy. Hi, Amber in Gulf Shores. Angela, and you're here finally. You know, we've been waiting for you. Whatever, and I do mean whatever. Angela asks, do you have, if you have a partial septum removed and there's still a little residual left, will that affect implantation? It's a good question, and it's not uncommon that there is a little piece of septum left over. What is a septum? So inside the uterus, some people have grow a muscular band that's called a uterine septum. And what that looks like, so let's say the uterus kind of normally looks a little something like this with the cervix down here. You've got an opening to a fallopian tube up here on each side. Some people have a uterus that's actually shaped like a little heart, and that's called a bicornuate uterus. Two cornua, two horns, we call that. But some people have that nice round uterus, but there is a band of muscle that's sticking all the way down the middle. Sometimes that can go all the way to the cervix. It can go through the cervix. It can actually even go all the way down the vagina, all the way to the opening of the vagina. So that actually means that these people have two vaginas. They call it a double-barreled uterus or even a double-barreled vagina. And you're like, what would I ever do with two of them? And your husband is like, this is an interesting prospect. Well, oftentimes one side is smaller than the other, but that muscular band inside the uterus can be associated with recurrent pregnancy losses or even implantation issues because the endometrium, the uterine lining that sits over top of that muscular band may not be as strong. Now, this has been studied, and actually pretty recently, the old way of thinking of this was that if there's a uterine septum, we must remove it. We must remove it because it's going to cause miscarriages. Well, when they actually studied that, they found that, well, lo and behold, it turns out there's not really a huge difference, but in someone who has had recurrent miscarriages or recurrent pregnancy loss or recurrent implantation failures who has the septum, in that scenario, it certainly makes sense to remove it. To be honest with you, the surgery that we do to remove it is so very easy. It is really simple because this muscular band, it just falls away. You take a pair of scissors and you go snip, snip, snip. It's a muscular band. It really doesn't have a blood supply in it, which may be one of the problems with the endometrium that overlies it. But it's really easy to treat. But it's not uncommon that you might leave a little bit left all the way at the top. Because if you keep snipping away at it, you don't want to snip away so much that then you actually go through the top part of the uterus. That's not a good thing to have happen. So to leave a little bit behind, I would not expect, Angela, that to really create really much problem at all. I think that is probably much more commonly a little piece there, 1, 2, 3 millimeters, more often than not. I think so. We've got the Foxy Angela here tonight as well, all the way from Minnesota. Good evening, my friend. Pooey is here from St. Louis. And oh gosh, let's see. Next week, I'm going to be in Tulsa. So actually next Fink and Friends is going to be live from Tulsa. I won't be in St. Louis, but I can't wait to get to your restaurant. and that is Sushi Station in St. Louis. Hi, Nina. Zenaida is here from the beautiful city of Miami, and she says, "Good afternoon, Doctor. Fantastic." And I'm like, "Oh, stop." Okay, one more time, just one more time. Logan says, "I may be a bit biased, but having a good therapist during this process is super beneficial." No, I think that is very much true, because the entire process here is very challenging to one's own sense of self-worth. In the fertility, we're constantly questioning the choices that we made in our lives and what brought us to where we are, and it's a roller coaster. So yeah, I do think having a good therapist is a very reasonable thing there. Postpartum Support International. Oh, how about that? Postpartum Support International has a directory of providers who are trained in perinatal mental health, and it is a great place to look for support. That is a wonderful tip, and I will absolutely pass that along and use that as well. Again, Postpartum Support International. It has been a clutch for Angelina Foxy in Minnesota, who tends to broken hearts herself. A wonderful cardiac nurse practitioner in Minnesota. Let's see, Marlena says, for FET post-suppression for endometriosis, is there data saying natural versus modified natural versus medicated cycles have a higher success? There is no data that says that one is better than the other. In fact, what we know is they should at least be equivalent, particularly when looking at modified natural versus medicated, because there is something about using that letrozole in a modified natural or an ovulatory FET cycle that may prove some benefit. However, as it pertains specifically to the post-suppression for endometriosis, to be honest with you, I have found that a medicated cycle is often a little easier to do, because even after your suppression stops or wears off, if you did Lupron, let's say you got your Lupron shot a month ago, or you stopped your Orilissa yesterday, that suppression can still continue to last a little bit, and things like ovulation induction or even your own natural cycle may be a little slower to restart. So in my opinion, using a medicated cycle just after suppression is probably the best thing. And what we know is that after suppressing for a positive BCL6 with endometriosis, I just actually read a study here. The success rates are very, very high, and always going to be the highest in that first cycle after suppression. People have looked at, well, is Lupron better than Orilissa? They both actually, in a recently published study, had about a 78% success rate, which is really fantastic. That's actually higher than the success rate you would expect with a euploid embryo alone, which would be about 65%. So definitely a believer there. Is it okay to do a hysteroscopy on cycle day 21, so 4 days after ovulation, even if the lining is not thin? Well, my question would be, gosh, I wonder why you're doing the hysteroscopy there to begin with. So, when we do a hysteroscopy, we want to know that there's nothing in the cavity that's trying to prevent a pregnancy. And as that lining thickens up, it can make things like a polyp or some kind of pathology in the cavity a little harder to see. So yes, you can do it at any time during the cycle. You absolutely can, but it is often a little more, let's call it, effective to do it in the beginning of the cycle. Now, as an experienced hysteroscopist, I would say there's no way that I'm going to miss some pathology, whether it's on day 5 of the cycle or on day 24 of the cycle. I don't know. Different people have different opinions over that. I'm comfortable doing it at any time. But the other thing that we do worry about with a hysteroscopy is, okay, if it's cycle day 21, and depending on the circumstance, but there's always some possibility that you could be pregnant then, and your pregnancy test would not be positive on cycle day 21. So that's really, to me, is kind of a bigger worry. Now, so we do a lot of diagnostic hysteroscopy in my office here. So these are people who absolutely could be pregnant at that point. Now, if you've had your tubes tied or have been dealing with other forms of fertility concerns such that you think that it's not plausible that you would be pregnant on day 21, maybe that's not as much of a worry, but it is a realistic consideration. Hi, Tanner. Thanks for being here this evening. And of course, I should have known Amber would say weightlifting. That's the type of exercise she recommends. But then again, Amber could probably bench press me and is much stronger in many ways than anyone I know. Hey, Sheila. Oh, my Glenda, I haven't seen you around for a little while. It's great to see you here tonight. And Glenda says, oh, my first IUI failed. Is it better to do the second consecutively? Well, we talked about that a little bit before. In my mind, doing it and getting closer to pregnancy is a good thing. The quicker you get to your pregnancy, the better you're going to feel. There's no medical reason that you have to take a break, or no medical reason that you have to go right into your next IUI. But remember, as I said a little earlier, each of those first 3 IUIs is as successful as the other ones. So if the first one doesn't work, it doesn't mean that you're at any lower a chance of the second or third ones working. Now, after IUI number 3, your odds, most of the time, if an IUI is going to work, it usually works pretty quickly, that your odds of success start to pretty quickly go down after that 3rd IUI. So I generally don't recommend people continue to do IUIs beyond number 3. If you want to do number 4, that's fine. But after that, you have to give me a really convincing reason why, because that mechanism, it's just really time at that point to look for a different tool in the toolbox. And that's an uncomfortable conversation that we have to have with some folks who want to keep doing it, let's say, because insurance covers it, but it doesn't cover IVF. And, I would say, well, getting it paid for is not the same thing as getting pregnant, because at that point, you really may just be delaying your pregnancy by doing something that doesn't have any higher success rate than regular old intercourse at home. So, but I digress there. Cycle number 2 and number 3 are just as likely as number 1 to get you pregnant, and you can wait or you can go. It depends on how you feel here. If you're ready to do it, I say by all means, go for it. There's no advantage to waiting, and there's also no disadvantage to taking a break. Let's see here. Pui says she misses. Thank you, Pui. Angela was in Colorado last week, so missed the live there. So I miss Colorado. Glenda is in Vegas tonight. I went to see the Eagles at the Sphere in Vegas, and oh my gosh, was that a great show. Had a wonderful, wonderful time. LS Moke, how to decide about 1 or 2 embryos is the question, and that's a very good question. So there are some guidelines from the American Society for Reproductive Medicine, and we generally try to follow those guidelines, which is to say it's really predominantly based on age. It's based on age because with age comes the probability that more, or I say at younger age comes the probability that more than 1 embryo will stick. And our goal is generally to get you 1 healthy baby at a time. We are really not folks who want you to have twins. And people say, well, why not? But I want twins. I want to just kind of get through it faster. Well, twins is a high-risk situation. It virtually assures you of a preterm delivery and potentially a very severe preterm delivery. It doubles the rate of cerebral palsy and autism. It significantly increases the risk for lifelong disability. And so we don't want to, we certainly don't want to do that. And we don't want to increase your risk without increasing the benefit. So if there is one good embryo that's going to get you a good pregnancy, we would rather say the benefit to you there is getting the pregnancy and not risking losing the pregnancy. So how to decide? I would say I start with the guidelines from the ASRM. Folks, my gosh, unfortunately, we are out of time tonight, but it has been so nice to be here with you, and I really appreciate you sitting in and being here with me. Thank you, by the way, also for participating in the Fuzzies with Fink. Please continue to send those positive vibes out there to everyone who needs them, because it's very important that we all understand that we are not alone, that this business of fertility is just a chapter in your book. It ain't your novel. And what are we doing? We're rewriting it together. So every step forward with kindness, every step forward with love, and every step forward with hope, knowing that tomorrow is indeed a new day, and it is full of all new adventures. I'm Dr. Randy Fink in Pensacola. Thanks for being here. See you next week from Tulsa. Good night.